Our first presentation is going to be done by Dr. Sullivan and Dr. Pinals, Disaster Behavioral Health Through the Lens of COVID-19. Dr. Sullivan is the commissioner in New York, and Dr. Pinals is the medical director in Maryland, and she's also the chair of the NASMHPD's Medical Directors Council. So let's go ahead, Dr. Sullivan.
Thank you so much, Brian, and thank you and Megan for inviting me to speak for a few minutes. It's really an honor. I'm going to give some thoughts that we've had in New York as at this point in dealing with disaster in the pandemic. And so it's going to include putting together some of where we think we are and some of what we think we've learned from where we are in terms of what we want to do in the future. So the first thing is I think that we became, during the pandemic, a huge support agency. We're kind of supportive of so many pieces of New York. And the big one first was the community. I don't think as a public mental health agency we were ever asked to be quite as supportive of a statewide community. So we started an emotional support helpline, for example, in March of the pandemic with volunteers because we didn't have the staff, and we trained those volunteers and we taught them some crisis stuff. We vetted them and we put them on an emotional support line. And that emotional support line, which has since morphed into dollars from FEMA, still sees primarily people who have never contacted mental health before. I think they're individuals, by and large, as we've talked to the people who've been on the helpline and worked with them, who need help kind of at the moment, or maybe even a little bit more, but they're not the kind of person who's ever going to walk into a mental health clinic, at least at that point in their lives, with the issues that they were facing. And I think that's an important lesson for public agencies like us to learn, that what is our role? What is our role for that community wellness as a whole? There's lots of apps and lots of things out there that say, how do you stay well and how do you deal with a crisis? But what's our role? And I think that's what we're struggling with. So something like this emotional support helpline, in addition to having calls, we set up groups, virtual groups where people could join, usually they were focused on something. So the groups would be focused on like family issues, just simple like family issues, or something like parent issues, something like workforce, working with colleagues, or dealing with the isolation of the pandemic. And people could come in at will to those groups which were led. And people got a lot out of them when we asked them what they were. So we're not doing that on a regular basis. We will do it now for the next year, probably through the pandemic. But what should we be doing after? So I think it's something to learn about the whole issue of prevention and how you begin to look as a public health agency. So that's one thing that we've been dealing with, going to continue to do. Then the second big support group was our clients. And that's where I think we all got incredibly involved with things like telehealth. We had to stay open. We had to stay involved. And we learned a lot about telehealth. We killed all those regulations. New York can get overregulated, so we killed all the regulations and basically have opened up telehealth in a big way, and telephonic to be used and we've pushed and pushed to get payment for it. And we've also are monitoring more than we used to, bed capacities and things to make sure they come back. There was a lot, we got more flexible in the state system. We opened up beds that we didn't have. So I think that flexibility and that monitoring and that making sure you're open. We did an interesting thing in the height of the pandemic. We looked at prescriptions prescribed the year before, and we looked at prescriptions prescribed during the pandemic, just as a marker. Are our clients probably getting the meds they need? And they were, thank God. I mean, it looked like people were getting what they needed. But that's another marker. Those kinds of markers you can use during the year and use data that way. And we really hadn't very much before, and I think we're going to do that more. And then we're also had to be supportive of our providers. And I think we're doing that even more now. We had to keep them open, keep them paid, make sure that they understood, infection control stuff, which nobody, even we were learning. And we worked very closely with the providers. So we were a huge support for them. And then we were support for all the other state aid. It was fascinating. I gave a couple of talks, and one was to the Department of Taxation, because the taxation department workers were picking up the phone for DOH. And they were answering calls all day long from people who were stressed out and and they were being affected. They found that their workers were having trouble just answering the phones. They don't do that usually. They just worked with forms and computers. So I think we became a support for all the other state agencies as well. And that's something that we did a little bit, but much more intense since the pandemic, and something I think we should continue to do. So I think we became support in a way that we hadn't been before. And that's something we're thinking about and how we should continue that. And then a couple of other quick lessons learned. I think one was about crisis work. Now, I'm not going to go into it because you've had so many sessions on crisis work, but we've learned that in New York too. Our crisis system's inadequate. It's got to be built. Thank God there's going to be dollars to help us build it. But we're also very concerned about making sure the continuum's there. So you're going to hear from Dr. Pinals about all of that. But the other lessons that we've kind of learned are also about disparities and data. And one of the things that we did with Project Hope was really break down the people who came. Project Hope is the FEMA crisis line, in a very careful way, understand what groups were using the line and disparities. And when we looked at it in the beginning, basically the line was being used, the telephone line, which was our primary focus, was being used by white people far, far more than Blacks or Hispanics. And we're coming from neighborhoods that were lower middle class to middle classy. And we said, God, we're not getting where we need to be because, well, that was good. That's good work. But we're not getting into the communities that we need to get into. And then we pushed really hard because a lot of it was initially virtual, but that very personal contact with the community-based agencies and the grassroots organizations, and to get into the communities, even during COVID, to get to vaccination sites. We went to vaccination sites to meet people. And when we did that kind of work and we got the real communities to work with us, the numbers went up for our Black and Hispanic communities using those services. And I think it taught us something, that you have to think about the modem you're using and how it reaches people. And you can't assume that you reach all people equally, even with the best of intentions. So that kind of thing is something that we've also learned. And so what we're going to be doing from now on is looking very carefully at all our data and breaking it down by race and ethnicity, and working with our providers and everybody else. Even with the QAR indicators, we're all used to those, how many patients with schizophrenia get their diabetes taken care of. Yeah, but we don't look at broken down by race and ethnicity. So we're going to start doing that so that we can know if there's disparities in the way we provide care. And that's a huge lesson learned, I think, and something that we're going to stick to as we go forward. And then just a couple of things about youth. In 4,500 families in New York State, as of August of 2020, had lost a primary caretaker or primary parent of a child. 4,500 kids. And how do we get to them? How do we make sure that they're getting the assistance that they need post-pandemic? And that's where schools come in and all the work. We don't know if we'll be successful, but we're working very hard with schools, very hard with outreach into schools to try to have the ability to get to families that might be having difficulties, especially with loss, but also all the other effects of the pandemic. I mean, it goes all the way from just the social isolation to actually losing a parent. So there's this big impact on our youth. And now they're coming back into schools. I mean, there's going to be masks and there's going to be distance, but they're coming back. So a big part of our work right now is working with those schools. And we've gotten into a big jump in our school-based clinics. And we're really very excited about this. We've gone up by about 200 school-based clinics in the past year. We're now to almost 900 across the state. And we're working with all the schools that are interested at all to put some mental health clinics actually in the schools. And that's been having great results so far. So I think that's something that we've always done, but not with the speed or the degree of intensity. And we've relaxed some of our crazy bureaucratic things that can make it hard to do that, so that they could get up and running in the fall. And we're continuing, and we're targeting certain areas that we feel we really want to work to get those in sooner rather than later. So the work with schools and the work with kids is important. And then I only had 10 minutes, so I want to end with something that we're so struggling with. And that's workforce. And you're going to hear something right after this about workforce. I think that is a huge issue. And we're not even close to solving it. I think the pandemic teetered a system that was barely coping a little bit with workforce issues into, at least in New York, into a crisis at this point, where we don't have enough nurses, we don't have enough people in the clinics, we don't have enough people to provide the services. Questions of why we're trying to understand. Some of it might have been people going to telehealth and leaving jobs where they were at, but I'm not so sure. I think it's complicated. And I think that we have kind of got the perfect storm right now of workforce, and still nationally and certainly in New York also an underpaid workforce, which is now, as other salaries are going up, make many, many things more attractive than us, as people are trying to recruit the limited workforce. So that's a major issue that we're struggling with. And there's lots of things we're trying. We're using some of the FMAP money that we all got to, for one-shot bonuses and things like that, but that's not a long-term solution. So we're still working on that. And one of the thoughts, and I'll end with this, was to really reconsider the workforce a little. Like when you have physician extenders, maybe we need to have more paraprofessionals who extend the work of our social workers and our psychologists and others that can get some work done, that don't require, they can come into the system without having had multiple years of degrees. We do lots of trying to recruit those, but maybe someone could come in and then we could help them get the degrees. So we're looking at a workforce that might be a little bit different. It's going to take time. It's a long-term solution, but I think we have to be creative about workforce issues, because I don't think it's not just recruitment. It's salaries for sure, but I think we have to get creative solutions. That's why I'm interested in listening a lot to the next session, which is going to be on workforce. But now I think I'll turn it over to Dr. Pinals to talk. I know it's going to be a great presentation. Thank you. Thanks so much.
Well, thanks, Anne. I think that you put a lot of color in your lived experience as a commissioner on what I'll be speaking about. So I'm going to just share some slides. But I think there's everything that you said relates to some of the work that we did in this paper that I'm going to be presenting on. And this was the second paper in the series that went through the Technical Assistance Coalition through NASMHPD, funded by SAMHSA, and worked on this. It's now available on the website. Somebody can send the link as we speak. Disaster behavioral health through the lens of COVID-19. And really the goal in writing this paper was to try and capture almost like a time capsule of what the history of disaster behavioral health has been, and then what lessons we've learned. And again, I think, Anne, your remarks really speak to what is in this paper. My co-author, Arlene Stevenson, was amazing. She's got a wealth of experience in this space and really helped drive some of the recommendations that came out of this paper. You all heard before, about these papers, where they come from, and recognize that the work is really our opinions and not those of the government entities that funded the papers. And also, although I consult, I don't have any commercial bias or conflicts of interest to disclose. So just in terms of highlights, again, the concept of emergency preparedness really continues to evolve and is really more and more integrating disaster behavioral health into overall preparedness. And I think the COVID-19 pandemic really drove this home. It highlighted also gaps that there have been in planning for epidemics and pandemics. Oh, we've got another scribbler. I don't know how that keeps happening, including disaster behavioral health as a part of emergency planning, and also focusing on disparities in outcomes as something that we need to continue to pay attention to, that we've seen in other types of disasters, that there's disparities in outcomes in impacts on minority populations that require intentional focus on health equity in emergency management. And as you heard yesterday, some of the issues around intersectionality in those disparities, the intersectionality of having a serious mental illness and being a person of color, for example, create huge needs that we really have to address with intention. So let me just, for those of you that are sort of newer, I know we've all lived through this disaster, we all have personal experience with it, but in terms of how disaster behavioral health or emergency preparedness is organized, I think it's helpful to just kind of walk through how this is organized. First of all, disaster preparedness requires there to be an emergency operations plan, an EOP, that is utilized to prepare and respond to an emergency. And after the 1918 influenza pandemic, there was a real need to include planning for pandemic influenza, which was recognized as something that might come again. And for everything we've learned with COVID-19, this will only get stronger because it is foreseeable that we'll have other types of pandemics in our future. And so being prepared is really part of this for prevention of worse outcomes. This also requires an incident command system structure that gets identified that will define lines of responsibility for when a disaster strikes. And then, of course, the COOP plans, the continuity of operations plans that are activated to assist an agency with reconstituting or continuing operations regardless of the disaster. And with the EOPs, there's always planning for all hazards. Any type of hazard has to be conceptualized, whether it's an earthquake, a fire, a pandemic, or whatever. And so these plans really have to be nimble in terms of thinking about if operations cease or and how you have to rebuild them, or how you continue in them during the phase of the disaster. The government agencies that are relevant for us, of course, there's lots of government agencies involved, and in this one, of course, the White House as the overall declarer of what was happening. But FEMA is our Federal Emergency Management Administration, and that serves to support federal and state government agencies that are struck with disaster. And back in July of 2020, the FEMA administrator commented that the whole country was, for the first time ever, in a state of emergency with 114 concurrent major disaster declarations, including the District of Columbia and the territories. So this was historic in that regard. And suddenly, as we all lived through, we saw major needs that we were not equipped to deal with. There was a surge capacity. Our hospitals became overwhelmed. I think New York lived through some of those first surges. We were all quickly learning from what New York was experiencing as the wave was reaching across the country, I think from the west to the east to the middle. And then this idea of needing to build supply chain for critical shortages emerged as a major issue. And FEMA is really responsible for helping to look at all of those issues across the country. SAMHSA, on the other hand, is the DHHS agency with responsibility to provide states, communities, and responders with behavioral health resources to assist with preparing, responding, and recovering from disasters. And disaster behavioral relief efforts, including the crisis counseling programs that you heard Anne speak to in terms of the work in New York and most other states that brought on the crisis counseling programs that became a mutual initiative from SAMHSA and FEMA. Now, how these all relate to the CDC is very interesting and complex. And I think having worked a little bit in Michigan and by the way, I don't work in Maryland, I do work in Michigan. But in Michigan, we've been partnering with the CDC and doing several different presentations along with other communities, really trying to help as the CDC is trying to figure out how disaster behavioral health fits into what they do as well. And then there's 5 phases of emergency management planning. There's preparedness, which requires the development of knowledge, gathering of supplies, prevention, the developing of plans, vaccines, mitigation that we saw for the COVID-19 pandemic, masks, physical distancing, contact tracing, high-risk population identification to target approaches, response, which included the deployment of PPE, personnel, whether it was through the National Guard or other entities, on call. We have, for example, we had a mobile staffing emergency plan as our nursing homes were struggling with staffing and the like, vaccines, and then looking at the response of the Strategic National Stockpile, which is a stockpile of medications and supplies that can get opened up, if you will, when a disaster is declared. And that's something that we talk about in the paper, especially as it relates to the need for psychopharmacologic agents being part of the national stockpile that aren't currently in there. And then recovery, returning to the workplace, which we're all pivoting towards, but also not quite, because we're not quite out of this pandemic yet. And then where does disaster behavioral health come in? It provides mental health, substance use, and stress management to disaster survivors and responders. And it was really established as a field. It's been an ongoing evolution of disaster behavioral health as a unique field embedded in emergency preparedness. In many ways, it really became pertinent and we became more sort of conscious of its critical nature after the terrorist attacks on 9/11 20 years ago, and then through other natural disasters and emergencies. And it's now seen as an integral part of emergency management, with the Disaster Mental Health Subcommittee of the National Biodefense Science Board conceptualizing DBH as including the interconnected psychological, emotional, cognitive, developmental, and social influences on behavior and mental health, and the impact of those factors on preparedness, response, and recovery from disasters or other traumatic events. And so what have we seen in our responses and experiences to date that are continuing? We saw state hospitals immediately pivoting, preparing as they were, seeing their COOP plans and figuring out what was going to happen as COVID-19 was coming, responding with patient cohorting, creating isolation units, quarantine units, changing programming, changing visitation rules, changing admissions, transfers, and discharges, with some states increasing admissions because the state hospitals became that safety net, and other states pausing admissions as they were worried about taking cases from jails and things like that. And then establishing ongoing guidelines. I think in Michigan, we're on our 15th or 16th iteration of our inpatient guidelines. And then PPE and testing, just establishing new practices, and now vaccines, of course. We really had to think about the acute system as well, with lots of our psychiatric patients routed in different ways, whether it was into general medical hospitals on what's called scatter beds, whether psychiatric units in the acute system was able to manage COVID-19 and psychiatric issues became a huge area of discussion. Access to getting medical supports onto psychiatric units when needed in case patients were decompensating medically with COVID-19. And this again became rapidly evolving throughout the pandemic. Crisis services, I'm not going to spend a lot of time on. You all know what's been happening with the shift to video, crisis call lines and the like, and really trying to make sure too that as our workforce in crisis services was working, that they were protected as well, and that people were being screened as they were coming in. Community treatment and residential services also pivoted dramatically with the shift to video, the extension of different kinds of modalities through video capacity, the initiation and the insurance that PPE would be distributed. The several entities, the APA, the National Council, were distributing PPE as much as possible to those behavioral health workforce sites. Again, visitation, staff callouts, OSHA questions, which continue. We have a regular conversation with all of our community residential programs, and a work group that we've often had our Michigan OSHA chapter, come and present, because there's so many questions that come up still to this day. And then, we can't forget, the interface with all these other populations, the homeless populations, as well as the criminal and civil justice interface, where court processes shifted, guardianship shifted, processes shifted, civil commitment processes, forensic services, all became more reliant on video evaluations, teletestimony, many states completely shifting their forensic activities to video, some even doing telephonic, lots of different things were happening. And the medication issues became a large part of our medical director's discussion, as clozapine, not wanting our patients to become unstable from clozapine, inability to get blood testing, long-acting injectable needs, thinking about people with opioid use disorder and the need to continue medication-assisted treatments. Loosening of regulatory requirements really helped, extending take-home dosing for methadone, for example, decreasing frequency of certain blood tests for those for things like clozapine, and then again using telephonic and video assessments for certain medications like buprenorphine induction. So you've all lived this tale, and really it's remarkable how much we've done. And so kudos to everyone. The lessons that we lay out in the paper, again, really to think about that time capsule, were many. One was really, what are the unique needs of our populations served in the public behavioral health system? We're seeing more and more data emerge about how they were increasingly susceptible and at risk to the sequelae of COVID-19 and to succumbing to COVID-19. Attending to the unique needs, behavioral health needs of the public health and behavioral health workforce, as well as the behavioral health needs of the population as a whole. So that's really when I've been in some of these webinars, we've been doing it with CDC and others, really looking at these three main components, as Anne articulated as well, for DBH, taking care of our vulnerable populations, the ones typically served by the public behavioral health system, taking care of our own workforce, as well as our public health partners that have to stand up the response, as well as taking care of the population as a whole. And I think many of us would say in our careers, we haven't seen this reliance on the public behavioral health system in this way ever before, but I think it's something that we have to think about as a sustainable activity that we're going to be involved in. And so now it's, we're seeing more and more disaster behavioral health as a best practice. It's only become more clear now. But that will require support of underlying policies and lines of responsibility. Taking stock of these lessons, there are wonderful resources available in addition to these papers that are coming out in this compendium, but that SAMHSA has produced, such as the paper they put together and the toolkit that goes with it around disaster planning for behavioral health. The challenges remain. Safety is a primary concern of our providers. They want to feel safe in doing the work that they do. We've talked about workforce shortages. We have to make sure our workforce feels safe and valued. We have to remember the psychological impact of these disasters and the need to integrate appropriate disaster behavioral health into all phases of emergency management. Limited access to providers, medication, and other evidence-based therapies will only destabilize our systems. We have to plan for this in our COOP planning. Telehealth and remote service provision is a great opportunity. It creates possible future directions. And then we also have to make sure that even with that we still anticipate and meet the needs of our priority populations who may not have access to that kind of telehealth and remote service. We have to get that financial infrastructure more stable and then look at things like vaccine hesitancy, which is just a first iteration of other things we may see on the horizon around how to make sure that persons that we serve are going to get the care that they need. So we came up with recommendations, 10 recommendations that are delineated in this paper with a little bit more detail, but I'll just go through them now so that we can open this up for discussion. One is bolster the integration of disaster behavioral health into public health emergency preparedness and response, incorporating the 10 essential public health services that require attention to prevention, response, and management. Also attend to health equity with specific efforts focused on needs of high-risk populations, including those that we serve. 3, a recommendation to conduct mass psychological distress screenings and opportunities to provide emotional support. So many people were making themselves available around the country at these vaccine clinics and wherever we could to make sure that there was availability for people to know that if they were in distress, there was someone to turn to that they could speak to. The 4th recommendation was to continue to promote behavioral health surveillance and research, really understanding the collection of quality longitudinal data, as Anne said they're doing in New York, to inform future disaster planning, including the psychological impacts of the disaster, as well as the long-term sequelae of COVID-19. For as many deaths as we've had of COVID-19, we've all had many, many more survivors of COVID-19, but there's a lot of data emerging about long-haul COVID and that impact and what that will do to behavioral health needs that we need to pay attention to. 5, the 5th recommendation was to foster communications focused on behavioral health needs. We learned that there's a very important role in sending out messaging about meeting the needs of the population in terms of that emotional support, but also listening to what the community is experiencing and trying to meet the needs in a bi-directional way. 6, attending to the mental health and healthcare of workers and responders who are reporting high risk of psychological distress, trauma-related symptoms. The studies that have been coming out from the CDC looking at the trauma-related symptoms of our own workforce is really remarkable and something that we should be paying attention to and really thinking about where trauma-informed practices really play a role in this disaster behavioral health response. 7, continue to build telehealth capacity. I think that's been stated. 8, continue to foster training on aspects of disaster behavioral health. SAMHSA offers a wonderful free online training called Just in Time so that anyone who wants to learn about the basics of crisis counseling can do so and then really build from there so that we have a workforce that's prepared and ready to help each other and help others. 9, maximize continuity and access to treatment for behavioral health populations. And 10, continue efforts to expand and develop a robust crisis care system. And I think with that, I will stop and hopefully we will have a robust opportunity for discussion and questions. Again, this just delineates some of what Anne said. It's all in much more detail available in the paper, which I hope people will take a moment to read because I think it provides a lot of rich history and again, that snapshot in time for what we've learned and what we need to do to go forward. And I think I'll stop there.
Thank you, Deb, and thank you, Anne. for people, please put questions in the chat box or put up your yellow hand and we will call on you and you can ask the question yourself. Just to get us started though, Deb, would you, and Ann as well, would you say a few words about the difference between addressing a regional time-limited disaster as compared to a national epidemic that appears to have become chronic at this point? So.
You want to start, Ann?
Yeah, I think one of the big things is the time factor that you said, Brian, that sometimes, although obviously results from those disasters can go on a lot longer too, but this has been one that has been really going on and will continue to go on. So the time factor in and of itself makes everything different. That whatever we prepare for, we have to be thinking of what we're doing now. We have to probably do for another 2 years. I mean, it's not like this is going to end or the sequelae of this is going to end. So it's not like you can put yourself into the flood zone, fix up some of the flooding and then move out. We're in it for a long time. So that's one big difference. And we have to be prepared for that. And especially in a place where there's underused resources. The other thing is the solutions are still not as clear. I think that there's still a level of, I mean, we're pushing very hard for vaccinations, but there's, as you know, this disparity in terms of how people view vaccinations. And we've been very involved in vaccinating the SMI population throughout New York because that's very hard to convince people. We've done little pop-up slots and things to, so you're doing things in this that you had not traditionally done before. We've become a vaccinator, not just for our state hospital system, but for the whole community behavioral health system. So I think that those things have made it very different. And I think it affects every age group in a different way, and the impact on kids and schools. You've really blasted the infrastructure of society in a big way. That year of isolation is tremendous. What did the isolation mean in terms of development of kids, in terms of older adults? So I think the work is much bigger, much broader, and really taps our creativity and ingenuity as to how we're going to deal with this over a long period of time.
Yeah, the only thing I would add to that is Lancet produced a paper in February of 2020 looking at the emotional impacts of pandemics and quarantine, and really looked at duration, boredom, change in routine, all as contributing to emotional distress levels. And that was pandemic. So I think what's really important is that we get data and research out of this to understand how we keep going. There's a lot of modeling around the emotional impact of disaster, but it is mostly built on those sudden acute disasters that, you know, like 9/11, that certainly have impact in a different way. But this chronicity, plus I think that, you know, we all have different starts of when the kind of trauma impacted us. You know, different people may have lost loved ones early on, or people may have been struck later by other factors that they had to pivot in their lives. So the beginnings and ends are not neat and clean as much as we would think from an personal, emotional perspective. And so I think we need to understand that a little bit more.
Thank you. And I'm down in New Orleans, and so I'm seeing the impact of regional disaster. And right now what you see is neighbors helping neighbors. They're really united to try and help each other. Would you say something, say a little bit about those type of situations and the impact on individuals affected, but also of the workforce, as compared to what's happened with the epidemic that we have a significant proportion of the population that's really anti-public health, and maybe say a little bit about how that has impacted direct care staff, providers, and has impacted the potential for having workforce going forward. If people are being insulted, attacked, it's generally kind of hard to attract people to work in that field and also to retain people. Would you just talk a little bit about how that has impacted behavioral health?
I have a couple things to say about that. Can I jump in, Ann?
Sure.
Yeah, I mean, one thing I would say is HHS has a model about the emotional impact. I showed it in the umbrella talk, But one of the things it looks at is in the beginning of a disaster, you see a lot of community cohesion. And then you see community unraveling, disenchantment, disillusionment. Things are so broken. How are they ever going to get fixed? So I think we do notice some of that in prior disasters. The other thing is the CDC did put out some really compelling data looking at the psychological distress of the public health workforce, and some of what the trauma they reported was feeling bullied, feeling like people, they were getting threats. I mean, we've really seen some very negative responses of the public to what the public health workforce is trying to do. And, that study did show that there were correlates, like people who didn't have time off, people who worked extended hours. There was another study at the healthcare workforce looking at people who didn't feel valued in their work, at work. So those aren't answers, but they may be some clues. And I think they align with what the National Study for the Center of Traumatic Stress says about how we get through as leaders in these kinds of disasters and things that we can try and tackle.
Yeah, and just to say that thank you, Deb, I think all those things are very important. And the vaccination, I think, has become a very contentious and divisive thing, which is, I think, a little bit unique in some ways to this situation. There was some very poignant, even I've heard from nurses and others of just seeing people die from COVID, which they felt could have been prevented if they'd gotten vaccinated, and people's resistance and then feeling futile. There's a pain in all that. Then there's the pain on the other side of the individuals who are very worried about vaccines, don't want to take vaccines, feel that that it's government that's forcing them. I think that particular division, sadly, as we begin to hopefully get a little bit further out of this pandemic, has divided people in a way that's made it kind of hard sometimes for that cohesion that you want in a pandemic, for people to come together. The controversy about schools and how kids are going to be masked or not. So I think it's sad in this epidemic, and I think it's made it harder. Especially, and on the healthcare side, I think for those who have to deal day to day with that chasm of trying to convince people to get vaccinated or feeling that they shouldn't be, it's an extra kind of wearing kind of issue that as a healthcare provider, we get really torn with. So I think that that's something we just have to try to understand and do the best we can with and try to help. But I do think that there's been tremendous support overall, and some of it dissipates, just as you say, Debra, some of it dissipates when the acute thing is gone, but overall, the communities, workers, people have come together in a tremendous way throughout this time. And I think that should be recognized too, despite all the rough spots that we're having.
Thank you. And building on that a little bit, when we look at what helps with resilience, whether it's, let's talk about the younger children, which haven't been vaccinated. We worry about what's happening to them, impact of not going to school, impact of going to school and then being quarantined, impact of wearing masks. What is it when you're looking at disaster preparedness, what is it that parents need to hear that will help them improve or strengthen the resilience of their children?
Well, I think it's important first that parents understand that kids can react to these things. And there's been a lot of work that's been done on, and lots of stuff written and lots of things out there for parents when they have the time to listen to about how to talk to their kids about things, how to understand that young kids can regress, other kids can have other reactions, how to deal with that with the kids, how to be straightforward. So a lot of it is helping parents know, it's hard stuff to talk about, but it's probably important to talk about it, and they need to talk about it. And how do you talk about it at different age groups? So I think some of it is working with parents and helping them deal with the issues that the youth face. And I think that that's really important. On the other hand, I think we don't pay enough attention to the communities and to the families that are just so overburdened. I know that, for example, families that can spend the time to help their kid with remote learning, or even help their child now going back to school with all these families who are doing 2 or 3 jobs, who are in lower income areas. I mean, the pressure on those families is so tremendous. And when the schools have looked at it in New York State, there's somewhere between 12 and 15 kids, they don't know if they're coming back to, they've lost track of them. in the public school systems during this pandemic. Lost track of them. they kind of send home letters, they call, but they don't know where they're hoping they're all going to come back to school in the fall, but they weren't sure because we lost them. And those are mostly from overwhelmed families. So there's that bigger population issue you have to worry about too. The kids can be resilient, but they're in families that maybe are in situations where it makes it hard to have that kind of resilience. So there's a lot of concern about kids. I think kids are tremendously resilient, and I think with how they can get through these things, but some kids won't as easily, and helping families and schools see the warning signs and then being there to help them understand what to do about it is very important, and supporting families that are kind of economically and socially and overwhelmed at this point in time.
Well, and that's where maybe, some of the recommendations around disaster, surveillance and opportunities, thinking, SNAP benefits or TANF benefits, going into different places where you have vulnerable populations, and pointing them to resources that are free, or even having crisis counselors there just to talk. There may be ways to think about more partnerships, bringing more partnerships in, to be creative about, again, recognizing that disaster behavioral health is such a critical part of what we do, and we have to support the parents and to be able to support their children.
Thank you. Commissioner Brown from Kansas made a point that he said we seem to average about over 50% of crisis services being provided to people that have never accessed community mental health clinic, community-based services in the past. So it brings up the problem of recruitment, retention. It also brings up the issue of technology and looking at applications that may be helpful, internet services that may be helpful. I know we only have a minute or two left, but would you just briefly say how internet services may help and other forms of technology may help with that workforce issue?
I think in terms of reaching out, and certainly, and you have to always keep in mind though that even technology is for certain groups. I mean, we still have people who can't afford cell phones or cell phone time or internet time, and we're getting better at it. There's a lot of, but keeping that in mind, what is available? I think that we've underutilized it. I think in public health, in mental health, public mental health. I mean, it's kind of striking that it's the private sector and all these startup companies that are doing a lot of this online wellness and interactive stuff that we haven't done really as much at all. And I think we've learned that lesson, and I think we're going to try to start to do more of it. So I think things like just open times where people can come and speak to each other like this. Text, I'm not a texty person, but lots of people are text people. And text lines have tripled. Our text line tripled in terms of this. But you can use a text line in a public health. It doesn't have to just be for a crisis. It can be for help. And we know that from the private sector that's out there doing this. So we have to look, I think, at where are the gaps? Where is it that the public sector needs to move in because all this private stuff that's out there isn't serving the need? And I think that that's what the future is going to hold. And I think we have to get better. We're even we have these PROS programs in your, called PROS programs in your state, which are rehabilitative programs. And we have never used technology in terms of like when you're home and you're learning skills and you're doing rehab, what's the technology that you can take home with you that you can do it on your own and then do better in rehab and recovery? We haven't used that as much as we need to, and we're starting to look at it. We used it, interestingly, during the pandemic, and the clients loved it. They liked it. They liked being able to go home with homework assignments and things to do. So we've got to do more of that, and I think that we're learning. I think we're a little naive about it, to be quite frank. In the public sector, we have to get better.
Thank you. Deb, any last words?
No, I agree with Dan completely.
That's always a safe bet, just to agree with Ann. Well, thank you, Ann. Thanks, Deb. And we really appreciate it.